Welcome, everyone. I know people are still logging in, so we'll get started in just a couple of seconds. I'd like to welcome everyone as you're still logging on. We still have a few housekeeping notes and a little bit of a recap, so we'll just get started. I realize many of you are still joining. I want to welcome you all to our second day of the Patients Redefining the Future of Healthcare in Canada Summit. Thank you so much for taking the time to join us today. For those of you who weren't able to participate on Monday, my name is Leah Stevenson, and I'm honored to be the event's facilitator. On behalf of the Summit Steering Committee, I want to convey my deepest gratitude to our keynote speakers, Carol Hopkins and Dr. Kwame McKenzie, who presented on Monday. The presentations moved us all very deeply and hopefully are inspiring all of us to determine ways we can contribute towards actions today that will move us forward towards a more equitable Canada where everyone has the opportunity to thrive. To recap a few of the key messages that seem to really resonate for many of us from the keynote speeches, Carol shared with us that Indigenous knowledge is distinct and evidence-based. Our Western concept of evidence needs decolonized. Language and land are medicines. We are human beings supporting human beings to the right of safe healthcare. We need alliances and partnerships. Like birds, we must spread the seeds of life. And like the eagle, we must each discover our own leadership. Kwame stated that we cannot continue to use a Titanic strategy in healthcare where one size fits all. If third-class passengers from the Titanic were supported getting off the ship, an equitable strategy, more people would have survived. If you're not counted, you don't count. And before COVID, we already knew that the determinants of health are the most significant factors affecting health outcomes and access to health care, and that racialized and low-income communities are at greater risk in pandemics. For people living with poor determinants of health, including and especially race as a determinant of health, COVID has disproportionately infected and affected them. The impacts of COVID, such as isolation, domestic violence, and substance use, have disproportionately impacted them. The resultant economic downturn and the reduction in healthcare services have all been worse for our most vulnerable neighbors across Canada. He stated that every intervention will increase disparities unless one engineers and co-designs for equity at the outset. He said that it should be illegal to not focus on equity, to run blind and say, we didn't know. We must have better data, and we must have an equity-based pandemic strategy and recovery plan. On to housekeeping. I do encourage everyone to take notes during the presentations and panels. Please note any important issues, opportunities, key messages that really resonate with you. A few people did have technical issues last session, especially when we moved into breakout rooms. If you are having technical difficulties, such as not hearing audio, try refreshing your browser, your web page. Also, our event producers recommend using Google Chrome as your web browser for a smoother experience. No, that was not a paid advertisement. If you have an unresolved technical issue at any point during the summit, please feel free to click on the help link to chat with our event producers and they will sort you out. After our 3 panels today, we will have a moderated question and answer session. Please enter your questions at any point during a presentation into the Q&A box, and our moderator will aim to have as many of them answered as possible. After the moderated Q&A, our day will end with breakout sessions. Patients and caregivers and patient groups will be in rooms together. Industry will be in a room, and all our other stakeholders will be in a room. We are aiming to create safe spaces for people to freely share their ideas. You can find out which breakout room you're in by going to the lobby where there's a table with all of the details. If you do not see your your name on the list and you identify as a patient or caregiver or a patient representative, you can go to breakout room number 11. If you don't see your name on the list and you identify as industry, you can go to room number 9. And if you're from another stakeholder group, then you can go to breakout room number 10. If you join a breakout room late and no one's there anymore, please join room number 11. When the time comes, it is relatively easy to get to your breakout room. So you just, right now you're in the sessions link, so you'd stay in this link, you scroll down to the bottom of today's list of sessions and you'll see a list of numbered breakout rooms. You just click on the room that's been assigned to you. Again, if you have any tech issues, just try refreshing the browser, and if that doesn't work, click on help for tech support. I encourage everyone to complete our evaluation survey, which will be sent out after today's session. And thanks to those of you who had the opportunity to fill out the survey from November 30th, our keynote sessions. Now I am pleased to introduce the magnificent Sharon Clark. After an incredible presentation last year on Indigenous health, Sharon joined our Summit Steering Committee this year, working incredibly hard alongside Save Your Skin Foundation, the Canadian Psoriasis Network, and myself to organize this year's event. Sharon is the Associate Director of the Office of Indigenous Initiatives at Queen's University. She has extensive management and leadership experience, having worked with government, nonprofit, and Indigenous organizations across Canada and internationally. Most recently, Sharon served as the program lead for Indigenous health at the Canadian Institute for Health Information, where she led the development of organizational cultural responsiveness and was instrumental in the planning and implementation of an emerging Indigenous health strategy. Welcome, Sharon.
Thank you, Leah, for that very warm introduction, and I hope I can live up to that. Anyways, I'm very pleased to be here. Good day to everyone who has joined us virtually for day 2 of our summit, Patients Redefining Healthcare. As Canadians, we're all members of different populations, and many of us are currently part of more than one population, and or some of us will be in the future. And each of us has our own experience with the health system as a patient, a family, or from within a health-related organization. So on top of this, we have all felt the impact of the COVID-19 pandemic on our work and home life. People have said that now that we're in this, we have this opportunity to build back better. What does this mean for each of us? Better care for those experiencing inequities, better data for better, more informed decisions, better value for all of us in the health system. What is your better? Tell us, we want to know. And today we have the opportunity to really focus down on 3 specific populations as part of our panel presentations. Populations being facing continuing challenges, barriers, and gaps. We will hear from some very learned people who will provide us with their thoughts, which will enlighten, challenge, inform, and advise as we prepare for our breakout sessions this afternoon. I really encourage participants to ensure that their voices are heard. We will be collecting your input, your ideas, your comments, your suggestions, your experiences for our documentation as we move forward. So we have a very, very interesting day to look forward to. So with that, I thank you for listening, and I will hand it off to Anna Telescali to begin the panels. Enjoy.
Thank you so much, Sharon. You've lived up to Leah's introduction and beyond, might I say, from our experience working with you. So thank you for introducing the day. I know I'm not the only one who's very excited about the content for today. As Sharon mentioned, there's a wealth of knowledge on our panels, and word to the wise, be ready because there will be a lot to think about and to be inspired by over the next hour and a half. And it's my honor to be able to moderate the day. Before I introduce our first panel, I want to remind everyone a couple of the details that Leah had mentioned. We're going to be having our first 2 panels followed by a brief scheduled break, and then we'll return promptly at 1:35 for our third panel. And as a reminder, after all of the three panels have presented, we'll have a moderated question and answer period with all the panelists. So please jot down your questions in the Q&A box as we go, and we'll do our best to address them all during this part of our agenda. Again, today's panels will focus on specific populations that have disproportionately poor health outcomes and are often adversely impacted by our healthcare systems. Panelists will share their perspectives about the experiences of these communities before the COVID-19 pandemic, during the pandemic, followed by some reflections about the future. Full biographies of each panelist can be found on our Summit portal. And without further ado, that brings me to turning the session over to our first panel of the day, which is focused on people living with mental health conditions. I'd like to acknowledge that Carol Hopkins was scheduled to join us today for this panel. However, we send our deepest condolences because she had to take a bereavement leave and has kindly introduced us to our first panelist of the day, who's starting off this session, Dr. Brenda Restool, CEO of the First Peoples Wellness Circle, who, again, Carol kindly connected us to in her absence. Dr. Restool will be followed by Ellen Cohen, National Coordinator of the National Network for Mental Health, and then Mary Alberti, CEO of the Institute for Advancements in Mental Health. Thank you again, and I turn it over to Dr. Restool.
Ani, Bojo, Wabsquest, Magisi, Dodam, Dokis, Dinjaba, Anishinaabe, and Dao. I come to you from the territory of Nipissing First Nation, and I thank you for inviting me to fill some very big shoes with my friend and colleague, Carol Hopkins. I'd like to talk to you today about some of the realities of mental health, or for us, what we call mental wellness in our communities. My focus will be primarily on First Nation communities because that is the work that both Thunderbird and First Peoples Wellness Circle does. As a clinical psychologist, some of my comments will be made from my clinical experience, but also from the work that we do in our organization supporting the mental wellness workforce in First Nation communities. What we know about mental wellness services in our communities, I would say, comes in two main statements. One is, I would see it as very much a patchwork of services that has always happened in our communities. And the second is that we have significant and many gaps in the continuum of care for First Nations people across Canada. So the reason that this is the case has a little bit to do, I think, with the fact that historically our services have been funded through the federal government, yet we know that mental health services are primarily held and provided through provincial and territorial services. And so there is a challenge there that automatically leads to gaps in services. The federal government has always looked at providing services to our communities in ways that are based on funding per capita as opposed to need-based funding. So what this has meant is that often the funding will support our community members living in a First Nation, and those amounts of dollars are based on the number of people living in the community. And so most of our services have often been in a prevention and a promotion service type capacity around mental health. And sometimes it has been very generic in terms of talking to people about avoiding infection and just living well. But it doesn't always address some of the more significant challenges that has happened to our community members over the last century when it comes to thinking about colonial traumas. And so we do see that sometimes some of our services that have been federally funded have been geared to addressing problems or deficits in the community. And what I mean by that is we've often been funded to address certain issues. For example, we have the National Native Alcohol and Drug Abuse Program, which is meant to address addictions issues in our community, and one of the longest standing programs to have been evolved that looks at mental health or mental wellness services. And NADAP-based programs can be anything from prevention and promotion to assisting in referrals for residential treatment and sometimes to aftercare. But the NAIDAP program is also one that began to highlight the importance of looking at culture as a significant and important variable in addressing mental wellness. And so I understand that my colleague Carol spoke about the importance of Indigenous knowledge and evidence as a critical base to understand how to address wellness. And I would say that the NAIDAP program was very much about that. It was about thinking about how we bring back culture, how we bring back our understanding of our wellness to help support and promote wellness. However, some of the other areas that has really focused on dealing with problems or deficits in our community is one such as the National Aboriginal Youth Suicide Prevention Program that looked at addressing suicide in our young people. This program started off very much as a program that was proposal driven. So it meant that not all communities had access to these types of services. And the suicide programs varied across the communities depending on how it was identified as a priority and what ways to address it. But a common factor in all of those programs and services, again, pointed to the importance of culture and language and Indigenous knowledge and evidence as being a critical component to addressing suicide in our communities. Some programs, some of our communities access programs that are serviced or funded by provinces and territories. And in those cases, they have often focused on specialized populations like child and youth mental health. Other times, access to programs are done through large groups such as territorial governments or through regions or through clusters of communities. For example, treatment centers, which are also NAIDAP funded, that have supported adult treatment centers and youth residential treatment centers, usually service a large region or geographical area, sometimes across one or more across the province. Others that have also looked at addressing things like trauma include our Indian residential school program that looked at addressing trauma, colonially based traumas and other forms of trauma. That has since been extended to looking at traumas related to murdered, missing Indigenous women and girls, and now our day school program. So again, that program is usually found at a regional level. And so we're starting to see a patchwork. There are some prevention programs in the communities. They're not always all the same. Then we have these programs and services across regions or territorial groups. And then we also see that some are provincially based. And that we can sometimes get additional access into our populations that funded out of in a First Nation. And I realized I forgot to mention one other program that is sometimes done through clusters is our mental wellness teams. And our mental wellness teams are often a collaboration of Indigenous cultural practitioners and mainstream practitioners looking to support mental wellness services in a community. In this case, and in the case I'd say of the Indian Residential School Program, all of these programs continue to focus on Indigenous knowledge and evidence, and they also take the lead from the communities about what are the priorities and what are the needs. So what I'd like to say is that there still remains a lot of gaps in terms of not all of our populations have their needs addressed. And we need to be able to work with our provincial system who holds the funding dollars to be able to do that work. So many of our communities, as I've stated, have noted the importance of culture as central to addressing mental wellness. And we have to be able to recognize that Indigenous people, First Nations people have talked about the First Nations mental wellness continuum framework as a model to addressing wellness. And I'll just say very quickly that a big part of it is recognizing that culture as a foundation to our mental wellness services. It means supporting the Indigenous social determinants of health with culture as a foundational piece, looking at breaking down silos, looking at shifting from input to individuals to outcomes for families and communities. It must be designed and led by communities based on their needs, their priorities, their values, their language, and their culture. And it calls upon other systems to provide quality care and to be competent and to ensure that they're collaborating and partnering with the First Nation communities and recognizing there is a need for enhanced flexible funding. During the pandemic, we've seen that those gaps in services and that patchwork has really highlighted just how difficult the mental wellness services are for First Nations in being able to get access to quality service. It has shown that there's a burden within our First Nation health system and that we don't have enough in our workforce to be able to address the needs within our community based on the current resources that are there. We have seen increases in mental health challenges to substance misuse, to violence, to anxiety and depression, and triggers to trauma and colonial trauma based on some of the public health measures that have been instituted for the physical safety of our community members. We have learned to pivot to virtual platforms through the treatment centers who have been able to pivot and provide online residential type programming to people in their homes, as well as to mental wellness teams who have also pivoted to a virtual platform, and Indian residential school member workforce as well. We though, however, see that we have challenges in connectivity and the infrastructure in our communities because it is lacking. We continue to have difficulties, particularly in remote and isolated communities who don't have the infrastructure to allow for those accesses to be present. And in many cases, our membership also lives in poverty and therefore lacks the access to the technology for virtual platforms. What we have seen instead is the shift back to land-based activities. Many of our communities went back to going on the land, teaching people to connect to the land, to harvest medicines, and to use those medicines during this time. We also saw that there was some use of access, using virtual access to provide access to cultural teachings, cultural activities, and language, things that could help really inform and improve wellness. We also saw that we use our social distance measures for community activities. So some communities did drumming activities that you would hear throughout the day. Somebody would stand at their home and they would drum and they would sing as a way to help manage mental wellness or anxieties and worries and stress during this time. We saw a shift to investing in food security, so people did not have to leave the community and didn't have to worry about financial needs, and also to ensure that we were nourishing people physically. And so there was a big investment in that area. We also saw an investment in harm reduction activities within our communities. In one community, they looked at bringing in managed alcohol that they distributed to the community members, and they talked to them about harm reduction approaches. We did see reduced access overall, however, to community services as well as provincially based services when they were needed by our members. This was sometimes because the services were closed or unavailable to the public, such as treatment centers, or because our communities had restricted access and so they couldn't leave to go and access provincial services. And in some cases, provincial services were also not traveling, and so there was lack of access to those services. So for us, our challenges remain with those restricted access that sometimes cause concerns for some of our members related to other challenges for them. For example, people who were in residential treatment programs who may have had to leave or couldn't go in because they were closed, had concerns about their child welfare needs, where sometimes they were required to go and get access to residential treatment in order to get access to their children and have their children return home. So having to work and support them to get other means of getting their needs met so they can get their children, get access or have their children return to their home, or included in the justice system. Some people needed to access these types of service to address their justice needs. And so it led to other challenges that we continue to see. I'm not sure where I am in the 10 minutes, but I will say very quickly, my reflections are this: how can we support First Nations communities and Indigenous communities? One of them, I think, is by advocating for Indigenous-led initiatives on mental wellness, by supporting things like the Mental Wellness Continuum framework that gives a really clear picture of how we can help communities to do the work that they have identified need to happen in their areas and in their communities. We can also advocate for provincial and territorial governments to be better engaged on Indigenous defined mental wellness services and how they can invest in those services that come from Indigenous models and based on Indigenous outcomes and evaluations. Finally, I think we can also advocate for investments on with with Indigenous communities to have better access to virtual infrastructure. Right now, our federal government is saying by 2030, but that is not soon enough. We need that to happen much sooner for our communities to have access to the services that they need when they need it and where they need it. We need to be able to advocate for the Indigenous social determinants of health with collective outcomes around families and communities instead of inputs to deficits and individuals by looking at strengths-based approaches to care. And we need to ensure that we advocate for enhanced funding for Indigenous mental wellness services that invest in Indigenous knowledge and evidence. Thank you for your time, and I hope I was within the 10 minutes. Miigwech.
Thank you so much, Dr. Restoll. I think you were within the 10 minutes, considering that we started a little bit later. So I welcome Ellen to please unmute and turn your video on, and we will begin with your next presentation.
Hi, I've unmuted. I've never really presented at this, so hold on.
Thanks so much, Ellen. We have your slides up, so just let me know when you're ready to go on to the next slide.
Okay, because I'm looking for... Okay, so, oh, too many things are open.
You are good, Ellen. You've got slides
I'm
up.
so sorry. I am so sorry, everyone.
Don't you worry. You just find your remarks. You're in good
Okay.
shape otherwise.
All right. I don't, okay. Okay, perfect. Okay, so good afternoon. I'm really sorry about that. I'm very nervous and I don't do well at presentations. So, and Dr. Restoll, you would be happy, we would have been happy if you went over time. Anyways, good afternoon. My name's Ellen Cohen and I'm with the National Network for Mental Health. I'm honored to be presenting here today at your 5th annual summit, Redefining the Future of Healthcare in Canada, on this December 3rd that marks the International Day of Persons with Disabilities. The National Network for Mental Health is an incorporated non-for-profit charity, the only non-diagnostic mental health consumer-run and directed organization in service to Canada. And over the past 6 years, the National Network has been actively participating within the disability community. And along with our partners from civil society, we've been working on human rights and social justice issues that are relevant to all people with disabilities, including mental illness. The NNMH plays a pivotal role bringing the mental health perspective to the disability table and bringing the awareness about the intersection of disabilities and mental health into this mainstream mental health sector. Today, I am talking to you about mental health and disability in this situation before the pandemic, the current situation, and the way national networks moving forward. And the 3 points for this panel are the state of mental wellness pre-COVID and related services, how the pandemic exacerbated this situation, and our recommendations for moving forward. With the rapid innovation response of the government, Health Canada and Public Health Agency, they did great stuff creating a mental wellness portal that supported the wellness information and information in regards to professionals, peer support, psychiatrists, psychologists, all that were available online through this website. However, that being said, they were taking care of the general population. and many, many people within our communities, the disability mental health community, were left behind. Plans now for future interventions post-pandemic and virtual transformations that are going to be occurring as a result of the pandemic. We need to ensure that they are inclusive and that everybody has access to those people with psychosocial disabilities, as well as people who have mental health issues and psychiatric disorders, who have disabilities, from the deaf community and all other communities within the disability community, intellectual disabilities. Oftentimes, the people within the disability community, the advocates of the disability community, have to search themselves for their own services, and they're forgotten. And once again, during this pandemic, at the beginning, they were forgotten. The way forward for mental health services and supports is to focus on the workforce, which absolutely necessarily is important, and essential workers. However, we need to remember that people with disabilities are also in the workforce, and they are also in need of mental health supports and services. I've just got some statistics for you. Canadians with mental health disabilities are over 2 million. And I can't see I'm sorry, I can't see my slide. Over 2 million Canadians aged 15 years and older have mental health related disabilities, and that's 7% of Canadian adults and youth. 4 in 5 Canadians have mental health related disabilities and at least one other type of disability. Among women, they are more likely than men to have a mental health related disability. And over 1 million Canadians with mental illness say that they require counseling services from a psychologist, a psychiatrist, a psychotherapist, or a social worker. 519,400 receive some counseling but require more, and 286,400 required counseling but did not receive any at all. And these are from Canada's Survey on Disability Studies, and it was published in 2017, 2018, the first one that's been published in quite some time. Before COVID, the mental health system, despite the billions of dollars of funding that flowed into the system, into mainstream mental health, or as I call it, mental health industry, before they were, with all the funding that was flowing into the mainstream healthcare system, people with psychiatric disorders and major mental illnesses continued to fall through the cracks. And this is prior to the pandemic. The Canadian mental health system has been failing people with mental health conditions, severe mental illness, and it's been lacking the capacity to meet the demands of people with mental illness for far too long. And we've been advocating that. Add to that the people with disabilities from the deaf community and other intellectual disabilities, sensory disabilities, who have mental health issues, are now even more part of the mental health community and the seekers of mental health supports and services. How has the pandemic exacerbated the system? Sorry. I'm looking at my notes too, so sorry. Since the pandemic, the government has moved quickly to try to create financial security in some regards, with the CERB. And and that was our first piece of evidence that people with disabilities and the deaf community who were suffering with mental health issues and who were just within a situation where we're all locked in and we were all stuck inside and needing extra funding, did not have access to that until there was an outcry from the disability community. And once again, they were left behind. The case, our major concern has been evidenced with the first wave of COVID and people who were suffering from mental illness and those with mentally ill. One of the examples, as I said, was the financial support through the CERB. It was rolled out and persons with disability and serious mental illness were the last ones to be thought of and receive it. Disability supports programs still don't reflect the cost of living needed for people with disabilities, and the cost can be even more now that people have no access to public transportation. They need to reach out to get groceries, to get supports and services that they would otherwise be able to go out sometimes and do themselves. Since the pandemic, the web resources that were created were deficient for serving the disability community. We have formed a mental health disability pan-Canadian COVID response committee, and we have a group of people from across the disability community to talk about the mental health needs within the disability community. Mental health is something that's constantly forgotten within the disability community, and it's a tough fight. Somebody was saying earlier that the lens that is used to look at mental illness is the medical model, which looks at the disease aspect or the symptoms and the treatment, whereas within a social model, we're looking at the barriers that are created that don't allow for people to participate in community. And during the pandemic, we're isolated as it is. And I say we're because I too am a consumer of mental health services. I also have episodic disability. So I am very much a part of my community. Mental health service. Sorry.
So sorry, Ellen, it's Leah speaking, and I hate to interrupt because this is very interesting, but just if you could finish up in the next minute or so. I know you're already in your recommendations to move forward. Thank you so much.
So people with mental web resources that are created. Let me go to that slide. Sorry. Moving forward. Okay, I have to get there, sorry. So moving forward, we need to be looking at people to co-design programs together with people with disabilities. People with mental health issues need to be included in those designs of programs. We need to build the programs and interventions with people who have lived experience with mental health issues, and that they need to be truly responsive and reflective to the community needs. Another thing is, one of the things that being in a disability community and being a person with a disability, we don't ask for what we need, and this is our right. It's our human right. We have a right to mental health and physical health, and we need to make sure that we all speak up and ask for what we need, and also reach out and advocate to the politicians, to the bureaucrats. We need to let them know that this is our right and it's not just a piece of privilege. And one of the things and one of the advocacy issues that I'm grappling with is the mental health community is very focused on the medical model, and we need to help them to see that there are other models that they need to consider, and we need to be looking at the whole person and not just the mental health aspect of that person. They are not their illness. We are people with needs. And thank you very much.
That's a great way to turn it over to our next presenter. Thank you very, very much for walking us through all of that. And I'll ask Mary to please unmute yourself and start your video and share your slides. Thank you again, Ellen. We'll come back to you both in question and answer.
Thank you so much. So it's a pleasure. I want to thank the organizers of the event and the conference. It's really great, and also for embracing mental health and some of the things that we have seen and what the future will hold for mental health as well. And so proud to be on the panel with my colleagues here. So I wanted to just start off by introducing you to the Institute for Advancements in Mental Health. We had the privilege of having to rebrand our organization right in the middle of a pandemic. At the beginning of the pandemic, we were formerly known as the Schizophrenia Society of Ontario. And about 3 years ago, we started down the road to really look at our name and the people that we served. And one of the things that we felt was very important to us to understand the individuals and families and people we worked with, and really understand if our organization was really resonating with them. We found out very quickly that what people told us is, and we feel this is very important, is that they no longer wanted to be known as a diagnosis. That mental health was really about being seen as a whole person and being seen very holistically. And a lot of the social determinants of health is what is really important for people with mental health issues and mental illness and living with mental health challenges. So that was really our inspiration for rebranding into IM, the Institute for Advancement in Mental Health. So I just want to take you through some of what the organization does. Is our mission is around innovating, supporting, and driving change with people with mental illness. And this is a fundamental change. As Ellen was saying, oftentimes in the mental health system world, a lot of what we do is very top down. And we often don't listen to people impacted by mental illness and people experiencing mental health challenges, which is something very much we would do if we were in a corporate sector or in a business sector. We would want to be able to meet the needs of our customer. So IM has pivoted to be able to drive everything we do alongside with people who live with mental illness. Beyond that, our beliefs in the organization is that the mental health community has been very siloed and often very times related to just a mental health system. We really believe that it is time to change that, and that it is not about which organization or which hospital, but all of us working together. Because if we come together as a community of people, we fundamentally believe that we can support people in a much better way. So here are some, we believe in partnerships and working together and not alone, and innovation. So one of the big pivots that we've done is we feel that the mental health system has been delayed in embracing innovation and embracing different ways of responding to folks who need help and different ways in responding to prevention. We also believe that within mental health, there has to be tremendous compassion and respect always for what we do, the people we do it with, and that we really need to look at impact and understand what people need so we can work together and come up with solutions for people, real lives, real problems. So as an organization, what did we see pre-COVID? We saw a system that was already overburdened and overwhelmed. It was a system that was not able to respond to mental health needs. We were experiencing access to care and access to service, enormous wait time for people trying to get help in the system. We were also experiencing that there was a lack of adapting and onboarding new ideas and new solutions to care. So oftentimes, we talk about what is out there. What are some of the things that communities have invested in themselves, even on a volunteer basis, and adapting and supporting individuals with mental illness and mental health challenges. So things that we saw, although we had peer-to-peer programs, and we say we value peer-to-peer programs, they were not fundamentally seen or still seen as part of a mental health care system. We often ignored, in terms of the lack of innovation, is understanding the experience of caregivers as well, and where caregivers, and when we talk about caregivers, we define that as anyone in a supportive relationship to somebody with a mental health challenge or a mental health illness. We saw there was a resistance to looking at doing things differently and kind of following our traditional service modalities in the mental health system. Our mental health care system, very siloed in our approach. We saw real disparities between hospitals and community working together, between folks living with addictions and mental health issues. Where could they go and get support and care? And how could organizations supporting both of these issues work together? The system that was extremely overburdened and underfunded. And although we don't always need to have lots of funding for what we do, but when we look at the percentage of people impacted by mental health issues and where and how we're allocating resources, there were a lot of folks who are not getting the help they need when they needed it. The lack of access to services was a huge issue and continues to be a huge issue pre-COVID, in that services were not accessible, both from a cultural language perspective, were not geared to communities and the needs of communities, and they were just hard to get into. So oftentimes seeing wait times for services of 3 to 6 months, if even that. Also a very non-holistic approach. Oftentimes folks who live with mental illness or mental health challenges need to have their caregivers, their friends, their families involved in their support and their care. And there was very much a discounting of the system being as holistic. We've seen it in younger populations of kids, of course, and children impacted by mental health issues, but how does that carry on through the lifespan? And we see that the system really fails to look at individuals as people and very holistically in terms of what they need and what they feel they need and what would help them in their resilience and recovery. So some of our first wave observations highlighted what we saw, and our organization very quickly had to pivot. As we went into the first wave, we were an organization that did not provide virtual services. We provided telephone support. We had to quickly understand how to change. But what we saw at the beginning is just the disparities in our mental health system. We saw a significant amount of programs closed and funds for mental health programs were reallocated to other parts of the health system. So in Ontario, we really experienced a suspension of programs, a closing of programs. So what we saw as an organization were people were looking for help and all kinds of help. And we also saw that people were impacted by the pandemic in very many different ways, and that their ability to get equitable access to services was not there. We saw significant gaps in funding availability and organizational needs. So I'll just, as a charitable organization, about 20% of our funding comes from government, the rest, which we have to raise on our own. So as many others in the charitable sector, and I'm sure many of you have heard this, it has been such a difficult period to be able to maintain services and operations, especially in the mental health sector. So our organization, as well as other organizations, had to decrease staffing. And while we were decreasing staffing, the impact that we had a 50% increase, above 50% increase in individual clients that we were seeing. We found that a lot of vulnerable populations were disproportionately affected. And we also saw that folks who were living with mental illness that had pre-existing mental health conditions were even more isolated than pre-pandemic, but were extremely isolated in the first wave. And we saw a lot of ongoing challenges with coping and isolation. So what we found is that people needed to touch base regularly. People needed help almost on a daily basis with dealing with the challenges that were going on. We found a lot of people reaching out to us with first-time mental health challenges that they had never experienced before and didn't know where to go, what to do, how to cope. So that's just very basic of some of the initial things that we saw. So as I mentioned, starting March the 16th, our operations became remote. We pivoted very quickly. We had to understand how to embrace video conferencing. We had to go online, and we had to extend our office hours into evening hours to be able to respond to what we were seeing. All of this without knowing how to do this. And just to quote Kwame McKenzie, who's been one of the speakers at the conference, is that, you know, the mental health system has had to pivot quickly in 6 months, what's taken us 25 years to talk about. So I think it was sort of an abrupt change that we had to go through. We prioritized, we had to as an organization with the volume of calls that we were experiencing. And I would just say this is not unique to us as an organization, but to many of my colleagues in the mental health sector, is really understanding how do we deal with the volume, how do we deal with the need. And that coming from the sector that we come with is that embedded in us is to support people who need help, and knowing that the normal places where people might have been able to access care, whether it was through some social support programs or whether it was through some of the clinical programs, was just not there for them anymore. And we delivered many of our groups virtually. So we expanded our modality of how we did things, really to be out there and give people that opportunity to have the support that they needed. And I can just give you an idea of what we saw by going virtually. We were able to expand our services across Canada. We saw people coming from across Canada. At times, we would have on our virtual programs 100 people on a call or on a Zoom call, asking questions, talking about their needs. So it was quite overwhelming for the organization, but quite overwhelming of the stories we heard from people as well. So what have we learned? So moving virtually was a very necessary step, both for the organizational survival that we had, but also to be able to meet the needs of our customers and clients coming to us. And this was not easy to do. It came with a lot of challenges and barriers, and we just had to understand how to do it. As has been mentioned before, what we've also noticed in the pivoting that we've had to do, the lack of access to reliable internet and people understanding how to do Zoom, how to function in this way. And also giving up of the face-to-face contact and being able to come and see someone in person has had a great impact on people. There is significant financial burden on organizations. We don't know how many of the organizations in the mental health space and mental health programs will actually be able to make it and will be able to survive. And the loss that will be at the community sector. And we've also learned that in order to survive in a very different world, you need to be very agile. And oftentimes in the mental health sector, our system of care is very traditional and may not be as agile and be able to meet the demands and the needs and be flexible enough to do that. So post-pandemic, there is an immediate need to rethink how we plan for a future of mental health. We are embracing at IM and with our community partners a future foresight initiative that will develop a report and scenarios given to the Canadian landscape on how we need to plan for better mental health and what will that look like, and how can organizations and partners and community-based groups be able to respond to what we are going to be seeing now and also going forward. How do we adapt to this new normal? There will be no going back from where we are now. It will not be the same as when we started down this road. So what will that mean for us? Also, what kind of financial considerations will be invested in the mental health sector? And this is of grave concern, is that with programs having closed and services having closed, will there be funding to reopen? What will be the mental health recovery model that we will have to look at? We've also seen, and I think this is very positive news, is that mental health is no longer just the mental health system, but we've seen the corporate sector, we've seen workplaces come up to the task of changing and the task of embedding mental health into the work that they do. So I think we now need to think about not just a mental health sector or a mental health system, but a mental health space. And that realigns us to the vision of our organization, which is redesigning society for better mental health. There is a huge need to come up with unique solutions to fill a lot of the gaps. I think post-pandemic, and we need to start thinking about it now, there are many great initiatives and programs and services that have been given birth through the community and through people who live with mental illness and mental health challenges. A lot of these are very evidence-based initiatives and services. How do we understand and integrate these as part of our mental health space and a good mental health response? And how do we really together think about doing things differently? So through what we are proposing as our innovation platform, which is a collaborative platform in the community, how do we talk about mental health challenges and come together as a community of partners to come up with mental health solutions that can be scaled very quickly and that really respond to the needs that we have? And these mental health solutions, through an innovation platform, fundamentally engage our customer and the customer experience in the development of these solutions. Post-pandemic, we really need to understand health and holistic health and consider both physical and mental health. So mental health is not just one little box that we're looking at, but it's actually just a fundamental part of everything that happens with our health and in the health system. And there is a real urgency to start working even closer together and understanding how do we share resources, how do we collaborate, how do we understand the issues that are out there, and how do we come together around solutions to these issues. And this is not just folks in the mental health system, but corporate partners, philanthropic partners, scientists, interesting and unusual partners alongside with our customers. So that's it. Thank you.
Mary, thank you so much for rounding out that amazing panel. I heard a lot of some of the problems that we're facing. You all talked about things like literal and figurative barriers to some of the solutions that are being proposed, like virtual care. But you also gave us a lot of food for thought for how do we co-design interventions and programs and responses moving forward, so that we're actually meeting the needs of our communities. So thank you all so very much for that. And I very much look forward to coming back to you for question and answer. It's now my pleasure to turn it over to our second panel of the day, which is going to be focused on older adults. So we had Jane Meadus, a staff lawyer with the Advocacy Center for the Elderly, who was going to join us, but unfortunately something urgent must have come up, which is not surprising in the line of work that Jane does with ACE. So it's my pleasure to turn it over to Louise Binder to open up the panel and introduce Edith Merchica, the Director of Home and Community Support Services with Mam Wessing North Shore Community Health Services, and Laura Tamblin Watts, Chief Executive Officer of CanAge. So Louise, I open it up to you to get us started on this panel. Thank you so much.
Thank you so much, Antonella. So welcome to all of you again on day 2. I hope you're having as much fun with this as we are and learning as much as we are. Just a few introductory remarks and then I'll turn it over to the real experts in this area. Just a little bit about pre-pandemic and older populations. Even before the pandemic, Canadians were worried about the ability of our health systems to provide adequate levels of care. So a survey that was conducted by the Canadian Association of Retired Persons last year, in that survey, they discovered that more than 90% of the survey participants said that they didn't think their provincial health system was ready to meet the growing demand for cancer care as the population aged. And indeed, I would suspect if weren't ready for that, they probably were not ready for other issues as well. So we're now compounding these challenges with huge backlogs in cancer care and in many other services required by older adults. So the question, I guess, is what's happened during COVID? Well, I think sadly, the news is clear. The demand for services has gone up, and people generally, by 2036, Statistics Canada is predicting that there will be 60% to 75% more Canadians aged 65 or older compared to 2017. That's really an astonishing increase. And as our population ages, the demands for all kinds of services, from screening services to diagnostic services to treatments, will also increase. We also know that during the first wave of the COVID pandemic, certain provinces were faster to respond for older adults than others. And sadly, Ontario really does not have a very good record in this regard, although I think we would have to say that most of the provinces certainly were not prepared for this outbreak in older populations. People living in long-term care homes in Canada were far more likely to die of COVID disease in 2019 than the rest of the population. However, the effect of COVID-19 on residents in long-term care provinces has indeed, in fairness, varied from province to province. Another shocking statistic is that Canadians age 85 and older account for more than half of the excess deaths reported amid the COVID-19 pandemic. And again, these are statistics from Statistics Canada. So Canada saw an estimated 7,576 additional deaths of older people as a result. And 52% were 85 and older, 36% were aged 65 to 84, and 12% were younger than 65. The future, well, we know that next week, the premiers are meeting with the Prime Minister to talk about Canada Health transfers. And I think it behooves us all to tell our premiers, our ministers of health, our public health officials, that we expect them to demand the appropriate Canada Health transfers that we're going to need in order to meet the growing demands that this pandemic has shown are required. The gaps in our systems are just too great. And so now with that, I turn it over to Edith, who will provide us more information about older adults. Edith.
Thank you so much, and good afternoon, everyone. Ani, bonjour. I'm Edith, and I'm coming to you from Sault Ste. Marie, which is within the Robinson-Huron Treaty Territory. And I am honored to be here, to have been invited to share a little bit about the work that I do for our communities. I work for a North Shore Tribal Council community that services 7 First Nations along the North Shore of Lake Huron in Ontario. So I've been doing this work for a number of years. It started out as through funding from the LIN Aging at Home program, and looking at how do we ensure resources for our First Nation elders. And so with the funding, it was often joked that my title quickly turned into the aging coordinator, which I was obviously not too happy with. So we are evolving from that initial growth within our organization and building on our home and community supports within the 7 First Nations I work with. So it's been a long journey, and I have reached out to our elders in the community to help me with this job. They have been my guide throughout the enhancements to identify the gaps in services, the resources that are required. And so we've been together for a number of years, and coming together in the virtual form, I thought it would have been great to have joined you from one of our communities and with the elder at his sacred fire, which he offered. And sadly, Dr. Rastool mentioned the lack of connectivity in our community. So we didn't have internet there. So we're resorting to being more in the city to join today. But it does speak to the lack of resources within communities that we struggle with. So I say Chimigwech to Dr. Rastool for actually setting the context of what I would like to share and build upon around the lack of resources for home support services within our First Nation communities, and the work that we've done to try and enhance those resources. Some of the struggle that I have had over the years is trying to access external resources, bringing into community to support individuals in home. There has been some struggle around the funding envelopes, the assumptions from external partners on whose role is it to come into community to provide services. And these have been ongoing challenges that I've had with trying to introduce these services to communities, which our communities should be able to access. And sadly, that has not always been the case. So the work that I've done, and I shouldn't say the work that I've done, the work that we've done has been to build those bridges with those services. But quickly realizing that we have to rely upon each other within communities. We have to rely upon our resources and all of our providers, and to build that capacity to take care of our own. And I think that's come to light with the pandemic planning that we've done at the community level. I've been invited to sit at a local LIN planning table and quickly realized that the conversations there and the planning in place did not reflect the needs within our communities, or would not meet the needs in the event of an outbreak. So what we introduced was an additional structure with the inclusion of an Indigenous task team for the North Shore Tribal Council communities. And what we did is we brought together our First Nation health directors and community partners to start a local response to planning. And when we started the conversation, we knew that statements were being made that in the event of an outbreak in one of our communities, there would be resources from Health Canada, the local providers would step in to assist. But what we realized as well is that we didn't know what that meant. So we wanted to really build upon our planning for a local response. And we have met every day from the onset, or every week from the onset of the pandemic, to start that planning at the community level, but also within our agency to look at how do we support, how do we begin planning, who do we invite to the table to help with this planning, so that what we put into place was reflective of our realities and what resources were available. So I'm so happy to say that we did get an amazing response from our local partners, the Public Health Unit, Indigenous Service Canada, Health Canada reps, our Ontario Health North reps, to assist us with that planning. And we identified 6 pillars to plan around, and recognizing that all of our escalation plans and processes would have to include our First Nation communities, as well as what resources were at the community level to support this planning. And again, it was more to realize that the response had to come from community. So I'm happy to say that we're still together as a task team every Monday morning. We come together to do that planning. But it's more of a reflection on how we've come together as communities to address our home care services, and really building upon that, that collaboration and building capacity in community as well. So I use this as an example of trying to ensure seniors are receiving services within their homes, and who is available to come to the table to ensure those resources are available. So I commented on the Senior Patient Advisory Council that was established to support that planning, and they were the ones to help guide that growth and identify the resources that are needed. We have a number of initiatives underway, including what does palliative care look like in our communities? What resources do we have to wrap around families and their loved ones when they want to pass at home, as opposed to in hospital or within long-term care? So that is an example of how we've realized that the answer is within the communities to do that. And we have maximized on the knowledge and the strengths within us to do that work, and just building upon that relationship that we have to look at other areas of needs. So really the current state, and within looking at the pandemic and how do we respond, we have realized that we have limited resources, but the collaboration at the community level has been amazing. And I'm always willing to share that approach that we've taken, not to say that we have it all figured out by any means, but I think we can all learn from one another. And that's really been my goal, is to share the work that we've done with other First Nations to assist in that, in those efforts. So I'm going to stop there. If you have any questions, please feel free to reach out to me, and I look forward to continue sharing the work. Miigwech.
Thank you so much, Edith. I will ask Laura to please unmute and go ahead, and looking forward to Q&A with all of you.
Thanks very much for having me. So when we're looking at the question of how are older people faring in the time of COVID-19, it's really hard not to get caught up in the long-term care question. And I know that my colleague Jane Meadis, who is on the call, will be speaking about the issue of long-term care in particular. So I'm going to leave our conversations about long-term care to Jane. And so what I thought that I would speak about a little bit more today is talking about how older adults have experienced social isolation and elder abuse in the time of COVID-19. And I just wanted to give you a little bit of a context of, where we were before and what COVID-19 has done, during the time that we've been really isolated in our own homes. So I propose to just kind of talk in my session about kind of where we were and where we are and what it's looking like that we're going to be going to from here. So I also just wanted to start off by giving just a very, very brief overview of the work of Canada's advocacy organization, which is my organization, CanAge. And during the time of COVID-19, we decided that the most effective thing that we could be doing to support older people was both answering the phones, and we certainly had hundreds and hundreds of seniors and family members reach out to us, and we tried to help and support and navigate them, but also to address the significant gap that we have in Canada around not having a plan for aging. And so Canada has been unique in OECD countries, and not in a good way, by not by essentially being the only country without a plan for aging. And so over the course of about 5 months, we did sort of thousands and thousands of hours of work consulting across the country in every jurisdiction with all political parties, working to crunch the numbers from key stakeholder organizations to review the myriad commissions and inquiries that we've had in the space of older people. And over that process, we came up with 6 compass points. And they are what you see here: violence and abuse prevention, optimal health and wellness, infection prevention and disaster response, caregiving, long-term care, home care and housing resources, economic security, and social inclusion. So I'm just going to touch on the points particularly around V and S, our violence and abuse prevention and social inclusion. So we're always trying to ask this question from a problem-solving perspective. So CanAge is very much focused on trying to move things forward and sort of make things better. But it is helpful to frame it within the context of age inclusivity. So in our roadmap for Canada's seniors, we again had 6 compass points, which you've seen, 40 issues across the VOICES compass points. And you can see issues 1 through 5 are here. And then if you go online onto our website or download the PDF, you will see that under each of those issues are a series of very specific policy recommendations that speak to the experiences both pre-COVID and during COVID-19. And so we have, again, 6, 40, and 135 very specific recommendations. So what was happening prior to COVID-19 in abuse and neglect, and then what's been happening since? About 1 in 10 older people will admit to having been abused and neglected pre-COVID-19. And like other forms of abuse, certainly we know that it's underreported. In 2015, we did a large community prevalence study called Into the Light, and I was part of that research team that looked at abuse and neglect in a number of different perspectives. So we looked at it from a financial perspective, emotional and psychological issues. I looked at it from physical abuse, institutional abuse, and that's certainly one that I know my colleague will speak about. And then also looked at it from the perspective of sexual abuse and neglect. It's important to remember that that study was limited only to members of the community. So it was not in an institutional setting. So it does not capture really that the experiences of people who live in long-term care. And it only was a response system for people who were themselves mentally capable of answering. So we know one of the big predictors of social vulnerability or abuse is whether or not you have cognitive impairment or not. So it's a limited study. And even within that, it's about 1 in 10. Well, we actually believe if you crunch the numbers in a number of different ways, we get to about 1 in 5 or 1 in 6 people will experience abuse and neglect. So it's a lot as an older person in Canada. We don't have capital E evidence. And when I say capital E, I mean it's the kind that you would hold up to a sort of scientific review, because the time of COVID-19 is still ongoing and numbers are expanding in contraction. But I can share with you some early information and early data that we have, which has been shared with the Senate and shared with provincial and federal governments in other ways, and certainly is a real challenge right now. Give you one example, and I'll just give you the Ontario example, but I'm happy to talk about other provinces and territories as well. During the time of COVID-19, we have seen a stark increase in 2 types of abuse and neglect in particular that we know about. Again, it's a hidden issue. One is it's been a rise in financial abuse. In some cases, we've seen, massive spikes, particularly in frauds and scams, often directly related to COVID-19, like actual COVID-19 benefit frauds and scams, or focused specifically on COVID-19 and money. We've also seen a significant rise in physical abuse, it appears. And so, we understand that often within the context of either people who are now locked up with their abusers, with people who were not able to go into the community in the way that they would ordinarily go to get resources and supports. The bridge games aren't happening. The walking club isn't continuing. And some of the, religious or faith-based organizations, which often provide some needed supports to some members of the community, are closed. So we're seeing that people are kind of locked up with their abusers and without those regular outlets. We're also seeing folks move home. And if we think about kind of the portrait of the abuse, about 2/3 of all elder abuse and neglect is perpetrated by those closest. So, caregivers, friends, and families are the overwhelming folks who are perpetrating elder abuse and neglect. That is now only offset by financial because of the stark increase in financial abuse. So it's not that there's less of the others, it's that there's more financial. And now it's about 50-50 stranger abuse and neglect for financial as it is for in-person. We've also been surveying across the country in terms of looking at both the response-based organizations and police organizations. And what we've seen, again, anecdotally here, doesn't live up to capital E evidence, but it is certainly persuasive, is that there's been a huge increase to resources for community-based organizations. So in BC, it might be, Seniors First BC or the Sail Line. In Ontario, you're looking at the Ontario Elder Abuse Prevention Ontario organization and similar. So giving you an example, there's been on average about a 10-fold increase in reporting to community-based organizations by seniors of abuse and neglect during COVID-19. But there has been a reduction, it appears, through early information and reporting to police. So people are more trying to reach out to community-based organizations and feel less comfortable having police involved. And that's a very interesting outlook. And it looks like, people are feeling less safe. Certainly leading off into our conversation, we are also very, I think, scarred by the stark realities of the types of institutional abuse and neglect that we have seen during the time of COVID-19. And certainly the military whistleblower report will never again kind of let us think about long-term care in the way that we did before. And it's important to know that many long-term care homes have done as great a job as they possibly can, and that there's wonderful long-term care homes, but there have been some where the outcomes have been horrific. And I just want to conclude the last couple of minutes by talking about social inclusion. So elder abuse and neglect and social inclusion are certainly related to each other. And we have seen a sharp increase in loneliness and exclusion from community-based folks as well as those in long-term care. So again, my colleague will speak more about long-term care. So I just wanted to share with you that, our issues that we included here that you can see are around things like loneliness, seniors and technology, transportation, ageism, Indigenous seniors issues, and intergenerational issues, all of which speak to that notion of social inclusion. One of my very first comments when we heard, in this case, it was the Ontario Premier, Doug Ford, say that he was going to put an iron ring around seniors. And then the next thing I heard was Dr. Theresa Tam talking about all people over the age of 70 should self-isolate. And I thought to myself, I wonder how the boomers are going to do with this, because for many people, recently 70 or above, they wouldn't necessarily consider themselves older people, and they may have never considered themselves as being vulnerable. And yet now there's this new narrative that because of COVID-19, they have increased vulnerability. Layer that onto people with pre-existing health conditions, the folks we're talking about, at this session right now, you have increased worry and increased isolation from broader community and existing supports. And we heard that with my colleague who was talking about how they had to pivot from the then named Schizophrenia Society, and even my colleague who just preceded me talking about community-based resources. We've needed another way of function, and that's been a real challenge as we've gone forward. So just to wrap, what can we do and where are we right now? The Voices of Canada Seniors is available for download, and it's also available in various accessible formats on our website. I've put some resources here, and again, happy to share the slides as well, of our organization and the Canadian Network for the Prevention of Elder Abuse, which is a great organization to go and it will help to locate you into other areas. And also the Canadian Centre for Elder Law has got lots more information on some of these issues. I would love to invite you to check out our resources and tell us your story. So one of the most important things that we do is collect stories, and we will have one of our trained team members, many of whom are actual trained social workers, reach out to you or any colleagues you have and walk through our process, whether or not you'd like help and support navigation. We try to assist as much as we can one-on-one. But if you have a story to tell, we will collect that and then work with you to see if you want to disclose names or not names, and so on and so forth, because we try to make sure that we bring the voices of Canada's seniors and caregivers and supporters into all of the work that we do. Got a lot of recordings and webinars and YouTubes and every other kind of great thing as well. So I just wanted to close by offering those resources to you. So again, what have we seen in some? We've seen a sharp rise in abuse and neglect, a sharp rise in social isolation. And unlike many other issues that have had addressing the violence, for instance, against women, and violence against Indigenous people and violence against children, have now had something like $743 million given to it cumulatively since the time of COVID-19. And there's been precisely $0 given to abuse and neglect, absolutely zero money being given to abuse and neglect on the issue. So we see a stark differential impact when we're looking at violence of older adults. Thanks very much. Happy and to enjoy our conversations together. And I know that my colleague Jane is now on the call as well.
Laura, thank you so very much. And Edith, we again gave us a lot to think about, and I have good news and not so great news. So the great news is that Jane was actually able to join us, like Laura said. So thank you, Jane, and sorry about the tech issues. The not so good news is that we're going to shorten our break a little bit and ask that we go on break now and everybody comes back at 1:35 for our next panel, which will proceed with as scheduled, and then ask Jane to please present before we go into Q&A altogether, just so that we're respecting the timing of the panelists for the last panel of the day. So I ask everyone, please come back after this scheduled break for 1:35 promptly. And of course, this is a scheduled break, but we welcome you to take breaks as needed throughout the entire session. So thanks everyone very much again. I'm looking forward to meeting you back here for our Q&A session.
Home is where the heart is. You hear that saying all the time. That's the base of a good, healthy living.
And one of the key differences between us and the mainstream programs is that reconnection to community. And that's what's really helping us. Our cultural worker and the program that she does helps bring people back to the fire.
We recognized before we even set up shop and started to serve people that it was really about taking them from the community that they're living in and creating community around them.
We often talk about, it takes a village to raise a child. Well, I think it takes a city to bring someone home.
I love it.
In 2011, we released a report called Our Health Counts. And that started the relationship with the city and discussing the homelessness of Indigenous people in Hamilton.
We did an Indigenous-focused point-in-time count where we had a magnet event, and we came up with over 43% of the people who we interviewed were experiencing homelessness that were Indigenous. And we're sitting extremely high compared to our 3% Indigenous population.
There is a housing crisis going on, and it's much more far-reaching than just Hamilton.
So when the opportunity arose to find homes for people where we didn't judge whether or not they had an addiction or a mental health problem, but we just wanted to help them, to save them from having to sleep on a cold street at night, it was a no-brainer.
The way that it used to be done is that you couldn't get into housing through a program until you started taking care of your addictions and stuff. But they found out that it's not possible for people, which is why housing first is the new best practice.
Yeah, absolutely. Immediate access to housing with no readiness requirements, with a recovery orientation. It's the only way to get people to be in a spot where they can look at recovery, is to get them into housing first.
And we never say you're not housing ready. We'll house you, and then we'll work on your other problems and your issues.
I worked at the same job for 17 years, and one day I just couldn't get out of bed. I just had no energy, and I thought, I just can't make it, I'm sick. After I lost the house and the wife and the kids, and all I had was like a sheet and stuff that I moved with, 'cause I moved with a cart.
Housing ties into all things health related. Somebody is unable to have a safe place to keep their medication if they don't have housing, which means it'll be stolen from them, it can get lost. Or if they need a health card, you have to have an address.
Well, I lost my house and I had heirlooms and stuff that I kept with me. And I got like all my income tax papers, all my birth certificate, this with my health card problem. They threw everything out of mine. Really personal things, my Bible, things like that. They tossed it like it was yesterday's garbage.
When you don't have housing, the barrier is to stack and stack and stack to the point where you don't feel like you can overcome them.
I don't know, I just became someone else after it.
So Rick was homeless really on and off for about 10 years, and he was very sick when he first was presented to Homeward Bound.
When I got here, I weighed probably 118 pounds. I was pale, I had pneumonia.
There was some COPD that was quite serious and undiagnosed. And, just that social disconnect, from family and friends.
And I happened to come here and they welcomed me with open arms. Anything they can to be on your side, to make you relax, to make you feel secure. Seeing me for who I am and not what happened. It gave me confidence again, that I'd lost.
It was his birthday soon after he came into the program, and we got him a cake and we sang to him and had a bit of a party. And he said that hadn't happened for 10 years, and that's a couple of years ago now. And there's a very big difference in the Rick that we see today than the Rick that we saw 2 years ago.
A lot of our clients have a lot of barriers that they have to face, whether it's bad credit, no identification, no bank account, having mental issues, having addiction issues, and they have so many barriers put in front of them.
I was a chef. Yeah. I want to go back, but yeah, it's my reserve, you know, and these graves are so full, you know. And what happened to my wife in Wiki? These drugs, you know, and she was 25 when she passed away.
When I first met with Dwayne, I actually met him at the health center, and he was pretty aggressive at the time, but it turned out that he has an acquired brain injury. I actually went to high school with him, and he is not the same person that I knew back then, unfortunately. He's had a hard run at life, and I'm glad that I was able to help him though, because a lot of people didn't want to deal with him at the time.
Oh, I'm here. Got this apartment. Yeah, I got this furniture here. I love it.
He needed a little bit of extra attention, you know. It wasn't just me that did it, it was the whole team that did it.
We feel blessed to be a part of our team because Homeward Bound is a little bit different than sort of mainstream Housing First models. For instance, you're not supposed to have healthcare on your team in Housing First. We have a nurse practitioner capable of doing assessments. She goes to people's houses. She's able to prescribe medication, and she makes those connections to get people to see doctors, to see specialists.
And we provide a supportive program for 2 years actually, which is very significant and I think very important because, you know, you can house someone, but actually sustaining that housing is a more difficult job. And I think it's because of our support and that we're there and we have regular follow-up and we check in very frequently. I think that has been the key to the success, for sure.
We've actually housed 193 people. That's as of March 2018, but we've worked with over 249 individuals just to get them to that point of even housing readiness. There's a multiple of different issues or barriers that one faces, and once somebody is housed, that's not eliminating all of those issues, right? So, and sometimes that's when a lot of that stuff comes to the forefront, because even though it's a
Hello, everyone, and it's my pleasure to welcome you back. Thank you again for your flexibility with our shortened schedule break time. And again, that's just what we had scheduled, so please take breaks as needed. It is my pleasure to get us started on our final panel for today, again, before we break out into Q&A. And before I do, I just want to remind you, if you have questions, please do jot them down in the Q&A box, and we'll do our best to get to all of them with all of our speakers together. So it is my pleasure and gratitude that I introduce our next panelists for our panel that is looking at income insecurity today. I welcome Angela Robertson, Executive Director of Parkdale Queen West Community Health Center, followed by Tracy Smith-Carrier, Associate Professor, School of Social Work, King's University College at Western University. Thank you again to you both, and I turn it over to you, Angela.
Hello there. So thank you for the opportunity to be part of this conversation. And in speaking about income insecurity, the lens that I want to take to this conversation is bringing an equity and an intersectional lens to how we have the conversation and how we think about income insecurity, and in the context of patients and redefining the future of healthcare is how do we think about income insecurity with an intersectional lens. So I think it is important to acknowledge, and the thing that I think we know, but important I think in this context to just keep repeating that we know that our health is deeply intertwined with our economic status, and both health and economic status are heavily influenced by social factors that are beyond the individual control. So when we talk about income insecurity and health, is that we're talking about system and therefore the need for systemic changes to ameliorate and address these sites of disparities. And that as well, we need to think about the broader social determinants of health. So when we think about income insecurity, we also need to think about the interconnections with issues of race, issues of ethnicity, issues of Indigenous identity, issues of gender identity, immigration status, and the rural-urban divide. So we cannot afford to think of solutions in a single strand because of the interconnected nature. I want to kind of frame a little bit when we think about income insecurity, the present moment that we're in. So we are in this present moment of COVID-19, a pandemic. And what we have seen with COVID-19 is the impact. We have seen the impact and the differential impact of COVID-19 on a range of communities and populations. So in the city in Toronto, where I am, we have seen that 79% of reported COVID-19 cases where racialized ethno-racial data was collected, we have seen that where ethno-racial data was connected, that 79% of the individuals who have been impacted come from racialized populations. And that really, this represents a 3.4 times the ratio of white populations here in the city in terms of COVID-19. And that of that, 72% of those who have been hospitalized have been racialized. And additionally, that we have seen the acuity in positivity rates among populations where low-income people live and reside, and where low-income people live and reside is also correlated with the presence of a high ratio of racialized individuals. I start there because I want to draw our attention to the fact that conditions that existed pre-COVID, so the disparities around income, the disparities around gaps in social determinants of health that existed pre-COVID was the stage setting for the differential impact that a pandemic like COVID will have and is having on populations and communities. So when we think about income disparity, no, we also need to think about how continuing to have these rates of disparities can become real fertile ground for exacerbating detrimental impact and consequences for populations moving forward when an issue like COVID-19 presents itself. And I think as well that we then overlay, we're in the moment of thinking about the coming of vaccine. And therefore, when we take an equity and an equity lens to the ethical conversation about who gets vaccines first, we also need to bring an equity lens that also look at who are the populations that are differentially impacted. So just feeling that as we have this conversation in this moment that we need to think about that. I won't go on at length about where the sites of inequalities exist in terms of income disparity, but I would signal that women still earn 78 cents on average for every male dollar earned. So we know that there continues to be a persistent disparity in that is gender-based in terms of income. And that when we look within the category of women, is that we see still a differentiated in terms of disparity, where you have racialized women, Indigenous women, earning less than their white counterparts. So even within the gender categories, where we see income disparity, is that their differentiated impact. One of the things that we know is that folks who are poor have poorer health outcomes. And they have poorer health outcomes because they have less access to good jobs, and good jobs we know come with things like benefits, and we know things like benefits comes with enabling access to good and quality health care. The other thing that we know is that folks who are poorer have a lower life expectancy. So we know that women who are poorer die earlier than women who are richer. Likewise for men as well. So we know that there is not just a theoretical in terms of perspective around these differentiated impacts, but there's a practical, tangible and detrimental impact for these sites of disparities. Some of the things that I think we also know is that folks who are poorer, when we look at cancer screening rates, is that they have lower cancer screening rates than their rich counterparts. And what that means is that if you have a lower screening rate because you're in the low income quintile, is therefore when you finally get screened and a cancer is detected, is the likelihood is that your detection is at a later stage, which then leads to a higher mortality rate for low-income communities. The other piece that I think it's also important to note, and I know that in the previous panel, there was, the focus on mental health, is that half of in terms of poorer individuals report poorer mental health, but also folks who are low income show up in emergency as their first point of contact to access mental health services and support. And we know that folks who are racialized, particularly folks who are Black, show up for mental health support through the justice system. So usually because there's a police intervention. So we know then the differential implications for low-income folks around mental health services and mental health impact, but then also racialized folks and where that entry for racialized folks and specifically Black folks in terms of accessing service. So when I think about and when I suggest to you that as we think about income insecurity, we need to think about we need to think about differential impact, and we need to think about intersectionality, and intersectionality being the various convergences of our identities that can produce different sites and different experience of inequality, but also magnify that inequality differently based on race, gender, sexual orientation, disability. We heard earlier in the earlier presentations around the differentiated impact for people with disabilities. And we know that people with disabilities have a higher a higher distance in terms of workforce participation because of discrimination in terms of hiring folks with disability, and therefore higher rates of poverty. So when we think about intersectionality, we need to, as I said earlier, we need to look at all of the sites of inequalities that folks experience and therefore map strategies that seeks to ameliorate those sites of inequalities and bring an intersectional lens to those sites of inequalities. And when we bring that intersectional lens in the context that we're in this moment, it's important for us to talk about the impact of race and racism. So the impact of being racialized and the impact of racism and the impact of anti-Black racism and anti-Indigenous racism. because we're in a moment particularly where we have seen that magnified by COVID, and we are in this, land of Canada, whereby we are very much subscribing to the notion of multiculturalism, and the notion of multiculturalism has really muted, I think, our ability to name racism, to name race and to name racism as determining factors for health. And I think this moment allows us to make that call. And we just saw what happened with our sister, Joyce Echequan, the Indigenous sister, in the Ottawa hospital, and what happened there as a current example. So this is not historic issues. These are present day realities that we must contend with. So when I think about what are some of the changes and sites of changes that I think we need to lift up to address the inequalities that are magnified by income disparity, is I think about two strands. I think about the policy changes, and I think about the basic needs, tangible changes. So my position would be that social policy is health policy. And therefore, the social policy and policies that I would recommend that we think about in our various networks advocating for is an increase to minimum wage. We saw in Ontario that was on the books, and new government change, and that was receded. That we need to have a good job strategy, and that these two pieces need to be twinned with the strategies that governments are lifting up as part of their pandemic recovery plan. Because pandemic recovery plan cannot be a return to pre-pandemic conditions for many of the populations that we are talking about, that when we say low income. And therefore, this moment, I think, also calls for some policy changes with regards to protection for essential workers. So when we think about income disparities, and who are the essential workers, is the essential workers are largely low wage earners. They are workers who are in precarious employment without benefits. And this is a moment that calls for some advocacy to correct that. Another social policy that I would say it's important for us to think about advancing is social assistance rates that are indexed to cost of living. So right now, if you're in Ontario, your social assistance rate is about $580 plus for a single individual. And we know that housing for a single individual is over $1,200 a month. And that's called affordable. And therefore, this flips me to, in this moment of that we need to think about one of the solutions around ameliorating and addressing sites of inequality around income disparity is a focus on rent geared to income strategies and affordable housing strategies. I'm sure others have talked about national farmer care, and in terms of the Brenda earlier in the first, I think, panel in this series, as an Indigenous sister, I think we need to think about and push for the full implementation of the Truth and Reconciliation recommendations, as well as the Missing, Murdered, and Indigenous Women's report recommendations. Currently, we're in the middle of a national childcare plan. We have seen with COVID that women have been dislocated from the workforce, but we know that it is not all women who have been dislocated from the workforce, that essential workers who are largely racialized are still very much participating in the workforce, but without the childcare supports needed. So a national childcare strategy is one. And then lastly, I would suggest that as somebody within the healthcare setting, is we need to think about how do we integrate what is now called social prescribing, social medicine, social care in how we deliver healthcare services that really integrates a broader determinants of health lens that can look to what are the differential supports that low-income patients will need as part of the prescription needed for them for better health. And I will lastly just comment on, as I know we're going to be heading into breakout rooms and talking about what are some of the tangible ways in which patient and patient networks can begin to plan and convene, is I think patient networks also need to think about different strategies around how to engage low-income patients. So we need to take a population lens and a population engagement lens to how we engage different populations, because just having a patient advisory does not mean that Angela, who is an essential worker working various odd hours, can have room to participate in those kinds of structures. And therefore we need to lift up different kinds of strategies to engage low-income communities who are pressed up against not having time for meaningful participation and co-creation in some of the strategies that we have been talking about. So I will halt there and look forward to the conversations.
Thank you so much, Angela. I think that was a fantastic presentation, and you brought together so much of what we've already been talking about today, so thank you. And I'm grateful to turn it over to Tracy for the next portion, who's going to focus a little more on the rural perspective too, so it'll be a great perspective to add here. Thanks, Tracy.
Thank you for your kind introduction. Yes, so I'm discussing rural poverty, and this is based on a literature review and community feedback from consultations that happened across rural communities in Ontario. So there you have the link there if you're interested in accessing the report. So these are some of the themes that came out of those consultations in the literature review, and we'll follow it up with the recommendations and action items at the end. So I know it's a bit of a whirlwind, but bear with me. I guess I want to first start with just a scenario. A mother sitting at a home, scared in case her husband gets home early and food is not yet on the table. There isn't a lot in the fridge except a few condiments. The house is drafty and cold, needing major repairs. The kids haven't come home from school yet. She feels depressed and overwhelmed. The internet is spotty and there's no one she feels she can call. This is an all too common story for rural residents today. While in urban centers, we've seen quite a bit of growth over the years. The areas of rural and remote Ontario and the rest of Canada have seen increasing outmigration, population stagnation, or limited growth in many areas. Rural residents accounted for 57% of Ontario's population in 1901, and this has declined all the way to 14% in 2011. These areas are not homogeneous. They reflect diverse community profiles. Some are associated with monolithic whiteness, although rural residents can present multiple identities based on gender, class, race, and so on. Stats Canada defines a rural area as a population of under 1,000 people. We know that poverty is a multidimensional concept linked to multiple determinants and consequences. There's no specific definition of rural poverty relative to urban, although there's an increasing acknowledgement that we can define poverty in a narrow sense or in a broad way. So the narrow looking specifically at a lack of financial resources to meet one's needs, and a broader one that acknowledges both material deprivation as well as the social deprivation that people living in poverty experience. It's also important to note that employment alone does not guarantee a life free from poverty in rural or in urban areas, and that there are many people and individuals and families that are working, often at multiple jobs, trying to make ends meet. Community attachment leads to positive health outcomes and mental health outcomes. It reduces stress, depression, and lowers our risk of mortality. It also improves self-esteem, increases levels of civic engagement, volunteerism, and participation. So those with close social ties have higher rates of self-reported health. COVID-19 obviously is challenging the benefits of these social ties. And we know that social isolation kills. Many poor health outcomes are linked to social isolation and loneliness. So people living in poverty, older adults, like we've heard, those geographically isolated or owing to cultural expectations or language barriers are often the most at risk for isolation. Rural Canadians with low incomes often sacrifice necessities like food and clothing to afford broadband service and spend a greater share of their income on it than the average Canadian household. Although Bell accelerated its rural internet rollout in response to COVID-19, particularly trying to ensure that, that kids in schools were able to go online during the lockdown, many communities and individuals still do not have access to high-speed internet or have spotty provision. There remains challenges related to the limited nature or fundamental lack of public transportation systems in rural areas. And we know that many people prior to COVID were making exceptionally long daily commutes to and from work. And so that transportation has often been through personal vehicle, so access or ownership of a personal vehicle, with very few or no local buses or infrequent or intermittent schedules of bus networks or transportation networks. Those unable to afford or access transportation face barriers accessing programs and services, and often those with mental health challenges must move to urban corridors to access appropriate services, leaving behind their existing social support networks. So speaking about the access to services, there's a gross underservicing of services in some communities. The social and economic restructuring that happened from 1998 to about 2005 involved the application of urban and market-based models of efficiency that led to many closures or the reduction of services. So this call to streamlined efficiency meant significant regional consolidation, meaning that services were only offered at the regional level. Oftentimes, these were at great distance away from local residents. So we also saw the retrenchment in health and social care sectors, meaning cutbacks in access to basic education, protection services, and less access to civic administrative offices or governmental services.
Hi, Tracy. Sorry, it's Leah stepping in, just asking you to, I know you have a lot of fantastic content. If you could try to get through, it would be appreciated. Thanks.
Absolutely. Just speaking about employment, there's obviously employment has been affected. You know, before COVID, we saw a lot of dwindling of the manufacturing and natural resources, some of those sectors, farming, agricultural, affected before. Those communities that are heavily reliant on tourism, for example, are even more in dire straits as a result of COVID. Formerly, intimate partner violence was believed to be pretty much comparable across urban and rural areas, but now we're starting to see research that indicates that it's higher in rural areas. This could clearly be because there are fewer options for women in rural settings to leave their abusive partners. And as we've already discussed, COVID-19 is compounding the isolation and the barriers that women in these communities are facing. We know that rural households relative to urban ones have lower incomes and can persistently report low income status and higher unemployment. Though the experiences of poverty might be similar across urban and rural areas, the experience of poverty is unique in those rural settings where the services and programs are often lacking. Actually, we have some research that indicates that food insecurity is actually higher in urban areas than in rural settings, although we know that, that food insecurity in the north is particularly dire with an upwards trend over the last few years. The problem of homelessness has largely been overlooked, actually, and underestimated in rural areas. There has been a tendency to focus on home ownership rather than rentals in these areas, and that there are a number of people living in outdoors in tents, RVs, cars, or in buildings that are not really fit for human habitation. Although a lot of people in the hidden homeless population wouldn't actually define themselves as such and are unlikely to access services as a result. I'm going to skip over this slide just because we've already discussed, we've had some of our panelists already discussed some of the issues that Northern and Indigenous communities are experiencing. In terms of health outcomes, access to health, we know, again, we've talked about the social determinants of health as being greater risk factors than those associated with, traditionally defined public health measures, poor diet, tobacco use, low activity levels. Although we know in health, there's shortages across the board, across the continuum of care, shortages of primary care workers and specialists, overstretched care providers, lengthy wait lists, confidentiality concerns sometimes in the community, and the lack of culturally and linguistically appropriate services. Right now, under the context of COVID, the focus is really on expanding virtual services, and of course, these present their own set of challenges. In terms of mental health and addictions, we don't have a lot of literature actually on mental health and addictions in rural areas. We do know that there's a lot of barriers in relation to infrastructure, shelters, mental health access points and crisis services are often lacking. People finding it difficult to access services because of transportation, because of those long wait times that we've discussed. So obviously having access to crisis beds and crisis mobile teams would be helpful, although again, we don't have a lot of literature or research that really has evaluated these in rural settings. This obviously will be necessary, particularly in the context of COVID-19, where we have such a focus on virtual mental health care. So in terms of recommendations that came out of that report, first of all, ensuring that everybody has access to a basic income for all Ontarians across Canada, too, in terms of especially the working age population, enlarging transportation networks in rural remote settings, encouraging job creation, access to mobile medical and mental health services, building community hubs and networks, and really trying to develop a research network to examine rural trends, because we really don't know that much. So much is focused on the urban setting. Addressing housing and homelessness issues, innovation in education and training, and obviously increasing our efforts to address conditions in Indigenous communities. So I'm just going to leave with you some action items for you to take a look at and for you to consider in the breakout rooms. Reviewing the principles of basic income provided on the BICN website, talking to your local politicians about some of the recommendations that have been made, and really working with our community partners and academics to create a research network to really look at rural trends and poverty and specifically. Thank you.
Tracy, thank you again so very much. We definitely have a lot to work through in our breakout sessions from everyone who has presented so far. And I am glad to be able to turn it over to Jane Midas from ACE, who we're so glad is able to join us today. And Jane, I'll invite you to unmute and start your video and carry on the conversation that we started back with Edith and Laura about older adults.
Okay, so you can see me, right?
Yes, and we're so happy to.
Okay, so thank you very much for having me. Sorry about that. There were technical difficulties. I was here the whole time. And I'm glad I didn't do a PowerPoint, so I can sort of just really focus on a few specific issues and kind of consolidate what I was going to say today, so we can get onto the Q&As, etc. So, when it comes to people in long-term care, there's sort of three main issues that I was going to talk about today. One is access to care, one is consent and capacity issues in long-term care, and the other is detention in long-term care. So, prior to COVID, these were all issues that we would see all the time in long-term care. People had issues getting access to proper care. People weren't, the homes were not getting informed consent from residents or their substitute decision makers, and people were being detained illegally. And, I'm a lawyer, I work in Ontario. So, my practice is in Ontario, and my experience is in Ontario, but most of this would fall in similar ways across the country. With respect to care, we always had issues around people getting care, there not being enough staff, people not getting, being rushed through their care services. And of course, once the pandemic came, this became markedly worse. One of the reasons is in most places, caregivers, so family caregivers were asked to leave, were told to leave, and were barred from homes. And they were really propping up the system that was already very thin. And they found that, they lost this care, plus the staff themselves were getting sick or were quitting. And so we had a huge staffing issue. This is being dealt with in different ways across Canada. But it has taken a lot of advocacy by very, very different groups to try to get more care. In Ontario, we have a promise of 4 hours per day per resident, but that's not until 25, 26. And that's not going to help today. And it's not going to help with getting staff today because there's no staff to get. That's the other problem, is we don't have enough staff. So moving forward, one of the things we have to do is to ensure that people are going into this as a profession, and that it's a profession that people want to work in. And right now it's a poorly paid profession. It's very difficult. It is, quite problematic given COVID and people getting ill. So they're going to have to change that. With respect to consent and capacity issues, when people go into long-term care, they often lose their autonomy. The homes stop talking to them, and they will provide treatment to people without getting consent from capable people. And they will go to substitute decision makers, even though the person isn't capable, or they just, they don't bother getting consent at all. This increased during COVID. We do know that a large portion of people in long-term care do have mental capacity issues, although they are never or very rarely formally found to be incapable. They're almost never provided their rights, as certainly in Ontario, we have a right to challenge those findings of incapacity. And because of family members not being in the home and substitute decision makers not being provided with information, there was has been a absolute breakdown of any kind of obtaining of informed consent in many homes. And we heard throughout that people were not hearing anything about their loved ones in the home, despite the fact that they would be the substitute decision makers for them. There's a recent article published with respect to the increase in the amount of antipsychotics during COVID in long-term care homes. And that was because people were getting agitated. And my guess is that those homes were prescribing those medications without getting consent, and that's illegal. And so moving forward, this has always been a problem, and we need to train and make sure that the staff, including the physicians and the nurses, are getting informed consent, which is the law in every province in Canada. You may have different laws, but everywhere you have to get informed consent from a person or their substitute. And this really just isn't happening. And it went so far as to have the homes were making decisions to not, for example, send anyone to hospitals. We had homes that did that, not treating people. And there's been a real failure, not only in the consent issue, but really in the way that we're treating seniors. With respect to detention, pretty much across Canada and across much of the world, although certainly the Western world, people in long-term care have been detained in their homes since March. In Ontario, since about March 22nd, perhaps a little earlier, but it was officially March the 22nd, people were detained using a directive from the Chief Medical Officer of Health in long-term care and retirement homes. That was about 140,000 people who have been detained. Long-term care residents were detained until September. At that time, they were allowed out for short visits without any interference for about a month, and then that changed, and they now again have to get consent and are again being detained if they're in a orange, red, or gray home zone, plus of course if they're in lockdown because of an actual outbreak. But people who are not in outbreak are being detained, and the way that they're doing this is not in accordance with the law. It's not in accordance with the charter. Detention in long-term care has always been a problem. Ontario, as far as I know, is the only province that has any kind of detention law on the books, but it is not enacted. So people across, seniors across Canada are detained in a variety of different kind of care situations without any legal authority. It's entirely illegal. It's not charter proof. You know, this is something that we, again, moving forward, we have to fight. And even with respect to the detention now, you know, yes, we understand that people are, you know, there is risk to people in long-term care who are very susceptible to these diseases. It's absolutely true. And we have to make sure that people are safe. But I'm not sure that, you know, detaining 140,000 people is the way to do it. And so I think we really have to think about, you know, how are we treating seniors? Are we treating them differently in a way under the law? Because people in other sectors where there are detention orders, where there have been issues, they're being detained in using an order by the Chief Medical Officer of Health, and those orders are challengeable in Ontario. But for people in long-term care, it's just sort of a stroke of a pen and you're all detained, and there's no way of challenging that other than going to court, which is very expensive. So I think that we have to really look at the rights of seniors and ensuring that we're respecting those, and ensuring that, you know, moving forward, you know, that we're not simply being paternalistic and detaining people against their rights. And you know, if you want to see what the residents think of these things, as you may know, the Ontario has a commission into long-term care into COVID, and the Ontario Association of Residents Councils did a submission to them, and you can hear the voices of the people and how they talk about being caged and feeling like caged animals for the last, you know, 8-9 months. And I think it's not a good reflection of society where you're detaining such a large number of people. We have to do better. So I'm going to stop there. Thank you.
Well, all I can say is, wow, Jane, thank you so much for opening up our thinking around this. I think these are a lot of things that we're not thinking about when we're supporting our diverse patient communities and what they might be going through. So I really thank you so much for joining us and being flexible with how to do that. I'm very grateful we got to hear your presentation. And now, just looking at the time, we are going to do our questions and answers. So thank you to everyone who submitted questions. Please do so if you haven't yet, and if you have anything to ask any of our panelists. I also invite all of our panelists, if you'd like to please share your video and just continue to stay on mute unless you are addressing one of the questions that come up. I'm going to start by bringing it back to our mental health panel, because we do have a question here that I'm just going to pull up that I want to make sure. Yes, so bringing us back to our mental health panel, and I just want to acknowledge before I turn it over to the Q&A that we've asked our panelists to provide a lot of information in a short amount of time, and I'm just want to point out how fantastic everyone did with doing that, and with giving us a lot of important information that we can again take back when we're making our planning. So thank you for doing that under such a short amount of time. I also, with that being said, we may go over slightly. I want to make sure we have enough time for Q&A. I know some of you may have to leave right at 2:30. Please do if you have to. But if for others, if we can stay on for an extra 10 minutes and recoup that time, I think it would be beneficial for our breakout group work. So this first question, going back to Dr. Restool, Mary, and Ellen, we know that mental wellness issues and addictions, including tragic unnecessary deaths, are rising during this pandemic, and disproportionately so in Indigenous populations. What should we be doing to turn this around? What should we be demanding from governments and other decision makers? I wonder if maybe Dr. Restool, you wanted to speak to that from your perspectives?
Sure, it's a big question. I was just trying to formulate a response in my mind before I answered. Yeah, I think it's a multi-pronged approach to what can we do. So hearing that we have seen lots of accidental overdoses, and we've lost many people to accidental overdose deaths in our communities. One of the things that we've been talking about with our partners has been around supporting information and education to our communities around harm reduction approaches. And that might seem like it's, that's a no-brainer. But what I didn't say in my 10-minute conversation was our NAIDAP programs were abstinence-based models of care. And so our First Nation and Indigenous communities have a very strong abstinence-based approach. And it's taking some time to work with our leadership in our communities and sometimes with our frontline workers to move to a harm reduction approach. There's a lot of myths and misunderstandings about what harm reduction is. And I briefly mentioned one community here in Ontario who did a harm reduction approach around alcohol management. And so they closed their borders during the first wave, and they negotiated with a local distributor to bring in a certain amount of alcohol at the same time that they were going to be distributing food in their food security program. And so people were allowed to also get a certain amount of alcohol when they got their food, so that they were recognizing that you just can't cut people off, that it increases dangers. And so I think that, what I heard was a lot of pushback about why are we doing this? Why are we giving people alcohol? We shouldn't. So there's a lot of those misunderstandings about it. So I think one of the things is really being able to help educate leadership and community members and community workers about harm reduction and why why those approaches work, harm reduction approaches work. We have communities who are now talking about moving into having access to harm reduction equipment, having access to needle exchange bins, and how that is helping people to meet them where they're at. And that's really, I think, part of the understanding of the work that we do in our communities is meeting people where they're at with what they need, which comes from a harm reduction philosophy, but I think also from that trauma-informed approach. Care that happens for us as Indigenous people is, are we ready to connect with cultural programs and Indigenous knowledge and evidence? And what are they comfortable with? How can we support them where they're at in addressing their addictions needs? So I think those are some of the pieces that has to happen. And I think harm reduction is something that requires a whole anti-stigma campaign in our communities. And I think a big piece that the NAIDAP programs did that we need to be able to bring back is that peer support piece. We don't see that as much in our communities anymore. So when I say that is, a lot of our NAIDAP workers were previously people who struggled with addictions, mainly alcohol at the time, and they ended up becoming our NAIDAP workers, and they've moved into leadership roles. They've often become chiefs. And so there was a real peer support about helping understand. So I think the same thing has to happen with substance misuse, is a real peer support approach to assisting us in our communities to see that we can help people to get better where they're at. I think some of the other things is helping communities find initiatives that meet their cultural needs. So being able to work across programs using some of the philosophies and ideas of our communities and values so that we all take care of one another is one of the ones I've heard. And what does that mean? How do we do that work? And how do we stretch the boundaries? So if we're offering services around, let's say, housing, before it was believed we only helped with housing in our communities. Now we need to move outside of our communities and look at what's available to ensure that our community members have safe housing, have, being able to advocate for social housing, doing a whole bunch of other things. So I think moving their boundaries outside of the First Nations or Indigenous communities. I don't know if that quite answers it, but I don't want to take up all the time. I'm sure Mary has something to offer too.
I do think your points about that stigma and harm reduction and actually looking at the problems to help challenge and reduce some of the distress that people are additionally feeling now during the pandemic, and how we go back to improving systems and helping to address what is a suicide pandemic really in our country in some of these communities. So thank you. And I turn it over to Mary or Ellen, if there's anything that Dr. Restall maybe missed in that kind of multi-pronged framework that you wanted to briefly add.
So I totally agree with what Brenda has said. I think a couple of the things that we say is that you can't have one solution for everyone. So I think we really need to understand from the perspective of what works in communities and what works for people. And also I think really focusing on that design by people. So we're very much, engaged in quite a medical model in the mental health system. And we know that system is overloaded. It's sometimes not effective, sometimes really doesn't work. So I think having an encouraging government to see the capacity of community and the capacity of self-determination and have that integrated into the system of care, right? So I also would agree 100% is that people need to be skilled in terms of supporting people in communities. And I think we've lost a bit of focus around prevention. I think we need to re-engage in helping understand prevention and really put some resources there for folks as well. So I think those are, a couple of the big things. And then I think human rights is a basic platform we need to be speaking about. Like healthcare and mental health care is a human rights issue. And I think we all need to become much more vocal with that. And there are parameters that exist around, precedents that I can say around how to do that. But I think that activity at the Canadian level has to be there because we have been talking about access to service, access to care and support for over 20 years, right? And we still have not achieved it. Funding is an answer, or reallocation of funding, but it's not the only answer. I think collaboration, sharing of resources, understanding, sort of community-based supports and how they're there, and how do we optimize that? And lastly, just that collaboration and integration of care. We have huge disconnects around, a medical-based hospital system and a community system. And how do we look at bringing those together as well as community-based interventions.
Thanks so much, Mary. Ellen, we do have another question for our older persons panel, but do you have anything to add that Mary or Dr. Restall missed that you wanted to make sure you shared?
I do, and thank you. It's really, really important that we ensure that we're engaging people with the issues and asking them and helping them to talk about what they need, because it isn't a cookie cutter thing and everybody needs specific things to respond to issues in their community, as well as teaching them the advocacy, the voice of advocacy, and ensuring that we're reaching out to all parties and all bureaucrats, because that's something we tend to forget. We tend to reach out to the party in power. Well, we need to reach out to everyone and just ensure that we're including people with the issues.
Thanks so much, Ellen. And again, this is great to take back to our discussions because it isn't a cookie cutter response. So Thank you. And I'll open up the question to our older persons panel. What can be done to hold governments or decision makers to account to ensure the best possible patient care? You're all doing some great advocacy work in this area. So maybe starting with Edith, if you want to, or whomever has a response, not to put you on the spot, Edith.
I can certainly, it's Jane, and I can certainly talk about that. I think that it is hard to hold them to account. I think it's, it is your, members of provincial parliament. You have to speak to them. The bigger your groups, the more bang for the buck you're going to get. There are a lot of groups around that are doing that kind of advocacy, but really is at, advocating at that top level. And participating in any of the, ongoing reviews and things that are, going on, whether it be, sending something to the Long-Term Care Commission. The Auditor General is still doing stuff on the long-term care homes. We had the Patient Ombudsman and the Ombudsman of Ontario. And I think it's important to get your voices out to, to people who speak, who are supposed to speak for us and are supposed to be, speaking for the vulnerable population. But, unfortunately in Ontario, we're not necessarily seeing that happen. We hear a lot of good words about iron rings and different things like that. And then, they go and do things like, giving licenses to homes, which, where the Canadian Forces came in, or taking away the ability to sue for negligence, and things like that. So I think it's really speaking up and making your voices heard.
Thank you. And I'll turn it over to Laura to add to, if you have anything to add to that.
Yeah, thanks so much. So, part of what I think is really important as well is to have a good sense about what level of advocacy you're trying to achieve at. Really wanted to amplify the idea, reaching out to people, but you can't reach out to everyone in every way all the time. You have to be clever and target specific. Are you trying to raise general awareness so people who are individuals are kind of getting a general understanding about what the issues are? Are you really specifically trying to change something? At which point you need to take a very specific and targeted approach, whether it's a broad campaign that then by sort of moral suasion and by media attention changes something, or like Jane was talking about, are you specifically commenting on, as I was last week, Bill 3, the Compassionate Care Act, where I was speaking very specifically to a specific piece of legislation. So first of all, set your goal at what you're trying to do. Second of all, understand, what your perspective is, right? So bring a specific perspective. Say, are you speaking on behalf of a large group of people? Are you sharing a unique experience? What other stakeholders do you have in the field? And then I guess the last piece is, and this is one of the things that we tried to help, is kind of know the issues and choose where the advocacy is, because too many words gets too big and you get lost. Professionals who are working in the field of policy don't do all your issues, and they really don't care about all your experiences. They mostly just want to know, what is it that you want and how much of an impact is it going to make? So, like long stories that aren't targeted don't help. Voices of people who have those stories do help. So I think collecting those stories and leading with the voice of an experience is an important one, but you have to decide if you're trying to make a policy shift. So just wanted to share with you again, the beautiful document is here, and you can see that I've just opened up the O for optimal health and wellness, because this is talking a lot about wellness. But as examples, you'll see very specific issues that have been coalesced in one place as part of our roadmap. And you can choose from a menu of different issues that we're looking at. And I'm just going to close by showing you that a very accessible version is online. So what you saw in a PDF, if you wanted to click on optimal health and wellness, you will see here, the issues. And then if I wanted to say, open up, I know we were talking about mental health and substance abuse before, you could click open and you would see some very specific recommendations. And so I'm not saying that this is everything in the world. It's not. But it is a roadmap which has coalesced some of the best thinking in the space on an evidence base. What we're offering to people is, this is a roadmap for Canada. We can all advocate at different levels and we can all take initiatives. So helpful to kind of be working on a scorecard basis about what you're trying to pick and choose, and then what is the evidence that you're giving. So CanAge is really happy to work with any organizations that are in this space, and we try to help support people at their systemic change level.
Fantastic. Thanks, Laura. And I'm sure we'll be in touch with not just you, but all of our panelists as we work together as patient organizations to focus in on what we can do together and taking into account all of these different intersecting issues that our panelists talked about today, and definitely using your resources and you as a resource to help us do that. So thank you. And Edith, before I turn it over to our next question directed at income insecurity, do you have any other points you wanted to add to what was said so far?
Sure. I just want to share the efforts that we've done at Memwesing is to get to know our funders and for them to get to know us. So it's a lot of relationship building. And again, it's more to demonstrate the commitment by the communities and the capacity to actually deliver the care. So it's not just filling out a call for proposal to get funded. We actually struggle with demonstrating within the community our ability to deliver on that investment. So I encourage all of our First Nation partners to attend those local planning tables and to be at the table when those initiatives are being discussed, and to come up with some of those solutions at the community level. That's really been the efforts that we've taken and built those relationships directly with the funders. Thank you.
Thank you so very much, Edith. And so before we just wrap up, I wanted to ask our last panel just a quick question that came in. It's not a quick question. None of these are quick questions, but we have a little bit of time left. And it's related to when we're discussing rural health and abuse, you mentioned it's often just lumped in with urban or it's forgotten. Rural areas are much more isolated and healthcare is so far away. They're also often talked down to as they're not often expected to have same levels of education, for example. Yet most have, that's not necessarily true. So again, there's some stigma. It can be so when help is needed, it can be 2 to 3 hours away and the police quite often don't arrive till it's too late. Any comments from, I guess we can start with Tracy on that divide and that stigma that might still exist. And then I would ask Angela to maybe speak to, from an urban perspective, one of the solutions that we've come up with as virtual care, just maybe some of the challenges that you're finding your community has with that particular solution. So I'll ask Tracy if you can comment at all on some of that stigma and challenges in the rural community first.
Absolutely. Clearly, there are issues with stigma, and we have ways to go still on trying to do some of that campaigning and some of the education around stigma in rural areas. I mean, even before COVID started, there was much more of a focus on trying to get virtual care out to rural residents. And for a lot of folks, for a variety of different reasons, that was working actually quite well for them. Particularly if there was accessibility issues, mobility issues, or even not wanting to leave their community and going into urban centers to access those kinds of services. So for the sake of convenience, that was very, very helpful. Now that doesn't always work for everybody. And like you said, these huge long wait times are significant. And I mean, one community that we went to, they were basically saying you had to wait almost 2 years before you could see a psychiatrist, which is far too long for somebody in crisis to have that, you know. So having access to virtual care can be obviously an advantage in trying to get care right away. But again, it's not helpful for everybody. And in some cases, if you don't have access to the internet, or it's spotty internet, or there are people in your home and you're worried about, you know, privacy and being able to talk about things, or in the case of an abusive situation, even being able to do that would be very, very tricky. So again, not for everybody, but can hold some promise for some people.
Thanks, Tracy. And I'm glad you said that because there was another part to that question and I feel like you acknowledged it. So thank you. And I turn it over to Angela, if you can speak briefly on that question of virtual care and just governments are focused on it as a way to solve our problems in an overburdened, under-resourced healthcare service or delivery system. Can you speak to virtual care use during the pandemic by people experiencing income insecurity?
Yeah, so I think when we think for us as a community health center, where over 50% of the people who we serve are folks whose income is below 25,000, is the issue of income security or income insecurity is certainly at the forefront. And I think one of the things that we have identified back to system planners is that we need differentiated strategies for low-income folks to enable continuation of care that's in-person care. So we cannot just close all services and say everybody moves virtual, because not everybody has access to devices. That's just one. And if you have access to device, you may not have access to a data plan that enables you to have a full half an hour engagement with 4 providers in a week. So therefore, while we think about this one size move everyone virtual, is we need differentiated strategies for low income and marginalized populations that require in person. Then the other piece as well is that we feel that it also means that some of the public spaces that folks have traditionally used to access device and connectivity needs to also look at strategies that enable them to be open. So we think about libraries in the urban setting is one of the spaces where a number of folks who are homeless, a number of folks who are low income, who do not have access to the kind of data plan have used. So we need to think about how those sites are lifted up and enabled to support low income communities. And then I think in the context of recovery, that recovery means that there needs to be a different digital strategy. So the province is thinking about a digital health strategy, and that digital health strategy needs to bring a health equity lens to that, that enables low-income populations to have access to connectivity, that enables rural communities to have access to connectivity. And, we know that, Indigenous communities and communities that are remote have often been cut off because there is a lack of access to digital connections. So virtual healthcare means nothing if you have no access. So I think this moment of recovery does call for urgency to address those long-standing gaps.
Thank you so much, Angela, for your response and for helping us conclude the Q&A session. I've learned a lot from all of you. I thank you so much on behalf of our organizers. And thanks for everyone for sticking through the Q&A that went a little bit longer than planned. I think the big message we hear about, if you don't get counted, you don't count. If you don't get noticed, you don't get seen. So I thank you all for bringing these communities to our attention at the forefront, so we can really be thinking about this as we move into our breakout rooms. And we look very much forward to, again, working with you all as we implement our actions. So thank you. So I invite our participants who are on the line. We are now ready to take this wealth of information to our breakout sessions. As a reminder, you can see the list of breakout groups in the lobby and locate your group by your first name and last initial. You can enter your breakout room by selecting it under the Sessions tab. If you're having a technical issue, try refreshing your browser. Otherwise, click on Help for tech support. Thank you again, and have a great session to all of our participants. Take care.